first. We are all right, so I'm going to go ahead and go through the roll call and see who has been able to join us this morning. Dawn Mottner, I believe I see you here. Dawn?
Yes, ma'am. Good morning.
Good morning. All right, Greg, I see you on camera.
Morning.
Chicky is excused today. She let us know ahead of time. Andy, I see you on camera. Kimberly, are you here yet?
I am.
Great. Good morning.
Good morning.
And Emily, are you with us?
Yes, I'm here.
Wonderful. Good morning, Emily. And Representative Notes, I see you. Good morning. All right, so we are going to get started. Thank you, everyone. We do have a quorum, and our first order of business is going to be approving the minutes. So we do need to approve the minutes both for our retreat and for September. And do I have somebody who is willing to make a motion to approve the minutes?
I can make a motion to approve those. Greg, thank you.
Thanks, Greg. Do I have a second?
This is Kimberly. I'll second that.
Thanks, Kimberly. All right. Dawn, how do you vote?
Approve.
Thank you. Andy, how do you vote?
Approve.
Thank you. And Emily, how do you vote?
Approve.
All right. So our minutes have been passed, and we are going to go. Whoops, I grabbed the wrong agenda in front of me. The first thing we're going to do is I'm going to give it over to Andrew, I believe, and Sarah. And, you know, one of the things I just want to say before we get into this conversation, we did have a really productive retreat a month ago. Appreciated everyone's input. We talk a lot, we engage, and then we don't get through everything we want to get through. And then one of the areas where we just didn't dive in the way we wanted to was around pharmacy. So I do want to encourage all of you today to ask your questions and engage around this. Pharmacy is one of our most expensive areas. We are also looking at adding GLP-1 drugs potentially in the summer. So we really do need to be paying close attention to cost controls around this. And we're going to be hearing from two of our carriers. We're going to be hearing from Moda and Providence. Kaiser will be hearing from in December. So we should have ample time to ask our questions. And we've asked Mercer really just to frame all of these issues for us that we're facing around pharmacy before we hear from the carriers. So Andrew and Sarah, I want to hand it over to both of you.
All right, thank you, Siobhan. Yeah, good morning, board members. Glad to be with you today to talk about pharmacy. As Siobhan mentioned, we had planned on talking about this topic in the retreat. We didn't get to it, and so we're deferring to today. And so what we've done with these first slides is to repurpose those retreat slides. And so when those retreat slides were originally developed, they were focused exclusively on a pharmacy RFP. And so what we've done for today is to somewhat repurpose those so that we can include some conversation around considerations for 2025 renewal. And so we will kick things off talking about the top drug categories. We'll have some conversation around general pharmacy landscape topics. We will spend some time talking about the RFP as well, levers to consider as well as trade-offs. And then we'll hand it off to Moda and Providence after that so that they can present as well. And so I have with me today my colleague, Sarah Drake. Sarah is a senior consultant in our Mercer pharmacy practice. She has a lot of great experience related to pharmacy, government, healthcare landscapes. And so I will hand it over to you, Sarah, if you want to kick us off here and start taking us through the slides.
Yeah, sounds good. Thanks, Andrew. I didn't get a chance to introduce myself at the previous board meeting. As was mentioned, we didn't get a chance to get to pharmacy. I've been with Mercer for about 7 years and worked on a mix of government and private employer clients and also state Medicaid programs. Before I came to Mercer, I worked for the Minnesota Department of Human Services, where I was the pharmacy director and the deputy director of healthcare purchasing. So I've got experience both managing public pharmacy programs and being a public servant myself. So I totally get the importance of pharmacy benefits and what that means to your employees. So I'm hoping that this can be really interactive. Please stop me, ask questions as we go. We're going to start with talking through just what we're seeing in some of your data for pharmacy trends, and then go into what some of the different levers are to manage some of those pharmacy trends that you could explore. That's where I'm really hoping we can get interactive. And then we've also asked each of the plans to, each of the carriers to provide some information on what they're doing around managing some of these top areas. So with that, we'll get started. The slide that you see here, I want to point out when you look at your overall pharmacy spend, and this is the most recent rolling 12 months that we have through March of 2023. What you can see is there's really 3 drug categories that are making up over half of pharmacy spend. It's over 58%. And if you look at those 3 categories, they're growing really quickly. Your overall trend for all of pharmacy is 12%. The growth rate for these 3 categories is much higher than that. If you take these 3 categories out, everything else is growing at 3%. So really, these are some of the categories we can focus on and really dig into because they're the fastest growing and really tend to be driving your pharmacy trend. And we'll talk about each of these in a little more detail. So you can see there's the immunosuppressants that represents about 35% of your spend, and it's growing at 21%. Diabetes, drugs and supplies, that comprises about 17% of your spend, and that's growing at 18%. What we call molecular targeted therapy, and we'll get into a little more what that is. That represents just 6% of your spend, but it's growing at 18%. All of these numbers are pre-rebate. We don't have the ability to link up rebates with the spending category. So there can be some, as far as the growth rate might look a little different once we would incorporate the impact of rebates, but this still is generally where the money and where the spend is. Any questions here before we dig into each of these categories? Okay, let's go on. So this is the immunosuppressants. So a lot of times when we think about immunosuppressants, we think about drugs used for transplant. While those are in here, they're a very small portion of the spend. By and large, these are anti-inflammatory biologic drugs that are used for conditions like rheumatoid arthritis, ulcerative colitis, and what we're seeing increasingly is used for dermatologic conditions like psoriasis or atopic dermatitis. So if you're like me and sometimes find yourself watching late night TV or NFL football, you might see a lot of commercials for some of these drugs. You probably recognize Skyrizi or Taltz on the list here. So what you can see is the net paid for the previous rolling 12 months and then the rolling 12 months before that. You can see the year-over-year change for each of these drugs. You can see it's pretty significant here. And then you can also see the year-over-year change in terms of the number of prescriptions. So the number of prescriptions is going up by 11% in this category, which is not insignificant. But then the net paid amount is actually going up by 21%. What I wanted to point out here, we've heard a lot about Humira, and there's biosimilars available for Humira now. But what you can see is that some of these other products are actually growing more quickly than Humira. Most notably, that's Skyrizi, which is definitely advertised a lot. It's also made by the same manufacturer as Humira. Also pretty strong growth in Xolair, which is used for severe asthma, and then Dupixent. So both Dupixent, Skyrizi, those are really being marketed for that treatment of psoriasis or atopic dermatitis, these dermatologic conditions. So some of the questions that we've asked the carriers is how are they managing some of these fast growing products? I'll stop here and see if there's any questions on what you're seeing here. Okay. Okay, we can go to the next slide. So this is the molecular targeted therapy group. And remember, this is a relatively small portion of your spend, but it's growing at that 18% clip. What you see here is these are drugs that are designed to really target certain conditions, and it tends to be certain types of cancer. And then also sometimes specialized conditions like multiple sclerosis. So you can see here the growth of these, top 5 drugs, and the year-over-year change is pretty significant. Triple-digit increases for drugs like Kesimpta from multiple sclerosis, and then Calquence, Rydapt, and Verzenio, all for different forms of cancer. And so these are the kind of things we're definitely watching and want to better understand how the carriers are managing these products and making sure that the members who are most likely to benefit are getting them, and that they're being used in the most appropriate way.
And do we have dates on when drugs become, generics can be used? For
Yeah,
each
so
of these?
these are probably, I think all of these are more than 10 years out for generics. These are relatively new drugs, so it's going to be a while before there's generics. Yeah, good question. And go to the next slide. So diabetes, I joke that I spend 40% of my day these days talking about diabetes and GLP-1s. So this is definitely the hot topic for all of the employer benefits folks. And so everybody's talking about GLP-1s, and you can see some of the reason here. So your overall diabetes categories, we saw it's growing 18%. And that's really being driven by these new products that are marketed for type 2 diabetes. So the GLP-1s there on the top, that's growing at 38% year over year. And it's now 40% of your overall diabetes drug spend. So you're spending more now on GLP-1s than on insulin, which is definitely kind of a swap from what we've seen in the past. SGLT2s, those are oral products. They're also used for type 2 diabetes, and they're growing at a good clip too. Some of that is due to some updated guidelines from the clinical guidelines from the Diabetes Association and endocrinology groups that really are encouraging use of drugs like the GLPs and the SGLTs earlier in therapy for people with type 2 diabetes. So that's not entirely surprising. SGLT2s generally don't have, people aren't looking for those to use for weight loss off-label, the way that you see sometimes people wanting to use the GLP-1s like Ozempic. You can also see here some growth in diabetes supplies. And a lot of what's driving that growth in diabetes supplies is increased use of what's called CGM, or continuous glucose monitoring. So these are, they tend to be little sensors that people wear on their arms that then hooks up with either a reader, a transmitter, or like an iPhone that allows people to monitor their blood glucose in real time. In the past, they were used primarily for people with type 1 diabetes. We're seeing them used more now for people with type 2 diabetes, and that's driving a lot of growth there on the diabetes supplies. We can go to the next slide. We're going to dig in just a little bit more on the diabetes category. So on the top here, you can see the different diabetes categories again. And this one, how it's different from the previous slide, it's looking in growth of prescriptions and also growth in the utilizers. And so you can really see those GLP-1 utilizers have grown by 42% year over year. SGLTs growing by 22% year over year. And everything else in the category is kind of flat or even negative. So it's really these new drugs for type 2 diabetes that are driving the growth. And then if you dig more into the GLP-1s, so that's the bottom table here. Here you can see some of the familiar names I'm sure you've heard of: Mounjaro, Ozempic, and you can see that those are really the top drivers, and they're really growing the fastest. Mounjaro is relatively new for diabetes, so you did not have utilization in that initial 12-month period. It was picking up. We expect that to continue to grow. And as you might know, Mounjaro actually got approval from the FDA for use under a different name, Zepbound, for weight loss. So that's expected to be on the market in the next few weeks. But if you
Sarah,
just look at that, yeah, go ahead.
Oh, sorry. I just want to make sure that I'm tracking. So because
Yeah.
these are our folks, right? These are PEB folks.
This is all, this data is from the PEB database. Yep.
Yeah. And so what I'm seeing here is our folks are using the GLP-1s right now off label, very likely.
Well, so we're going to get into a little bit about what's being done with the carriers right now as far as utilization management. I think that might be part of it. There might be some off-label use, but it's also just, increased prevalence of type 2 diabetes and then increased use of these newer drugs earlier in care for type 2 diabetes. So some of that updated guidelines. But yeah, you
Okay.
can't deny the Ozempic factor. 71% year-over-year change in the number of prescriptions and the paid amount. It's hard to ignore that growth number.
Thanks.
Any other questions on the what you're seeing here for the data on some of those top 3 categories, including diabetes? Okay, let's continue. So this is where we're hoping we can be really interactive and really think through how the board wants to. Oh, I got a question. When you generated this data, is it for the whole population or just, it is the whole population, the whole PEB population. So this is all of the PEB data. So the SGLT2s, yep, that's also very appropriate for people with heart failure. So that would include those individuals as well. Okay, pharmacy landscape. So here we want to talk about, here's the different options that are on the table for if you're looking to manage drug spend. And I think as Andrew mentioned, pharmacy is one of the largest categories of spend. And then, we know that you have limitations as far as the growth of the healthcare expenditures year over year. So when we talk about managing pharmacy spend and trend, typically it falls into 3 buckets. So there's drug management, and that's management of which drugs are covered and for whom. There's channel management, which is management of how the drugs get to the members. So where are they distributed? Who is distributing the drugs? And that includes things like what pharmacy network are members allowed to use. And then the third bucket is vendor management. And so that's management of your vendors, be that, specialty pharmacies or your carriers, the vendor that you're using to process claims through the carriers, that kind of thing, or maintenance of clinical programs or point solutions related to pharmacy. So we'll dig into each of these and have a little bit more of a discussion of, what the current state is and what other options might be to think about. So if we go to the next slide. So when we think about drug management, back in the old days, we always talked about the generics drugs and brand drugs. And like everything else, it's gotten more complicated than that. And we won't go through all of these, but you can see these are all of the different kind of drugs that are on the market. And typically when you work with a PBM or a carrier, you want to look at what the strategy is for each of these different types of drugs because it's very different. So how you might manage something like a cellular therapy that could be $400,000 for one treatment for one patient is very different than how you might manage something like a traditional generic drug that can be dispensed at any pharmacy at very low cost. When we think about how you can manage drugs, we look at either the formulary, and that's the which drugs component, and then there's utilization management. So that's the when are those drugs covered and for whom. So who's eligible to receive those prescriptions? So we'll dig into more of each of those. So if we go to the next slide. So drug management, we look at formularies. So that's what drugs are covered. So there's different types of formularies out there. We hear about open formularies. That's basically where everything is covered. Exclusionary or closed formularies means the carrier, the PBM, can choose that there's some drugs are covered and some drugs are off the formulary. Usually, if there are exclusions, those exclusions can be covered on a case-by-case basis through a medical exceptions process. And some employers are looking at more generic-centric formularies, so really trying to push generics when all possible. There's also different options for tiering. We see 2-tier formularies, 3-tier, 4-tier, and that has to do with what the cost sharing is for the members for those different tiers of drugs. Some carriers will have something called a non-essential drug list. So drugs that are excluded from the formulary deemed as non-essential. And those tend to be products that they might be things like a combination of two individual products that are available as generic. But once you put them together, the combination is very expensive. And then some formularies are managed to lowest net cost. Where you are today for PEBB, so you're using an exclusionary formulary, and it's a 3-tier structure. So something that, you could think about looking at, or we could talk to the carriers about is, would there be a benefit in going towards something like a 4-tier structure or more? But right now you're at a 3-tier and you are at exclusionary, which is in line with, I would say, what most employers are doing right now. We can go to the next slide. And then other component of drug management is utilization management. And there's 3 components of utilization management we talk about in pharmacy. So there's quantity limits. And so that's usually a limit on each prescription of how much quantity a member can get. And that usually makes sure that the members are getting a clinically appropriate quantity, not too much, and something that's safe, which is really important for something like an opioid prescription, for example. You want a quantity limit to make sure members are getting safe doses. It also can be used to make sure that there's not waste in the system. The members aren't going to get more than what could reasonably be used, or so it's not getting stockpiled or wasted. Prior authorization, so that is something that's put in place that a member needs to have approval before that prescription can be paid for by the plan. And so prior authorization is something that we've talked about in a lot of these categories. Certainly the molecular targeted therapies, we would expect there to be prior authorization in place. And then step therapy. So step therapy is steering members towards drugs that can be used for the same condition that are maybe a lower cost alternative, and the member would need to have a trial of a step therapy before they could get approval for a newer branded agent. Step therapy is usually considered the most disruptive edit from the member perspective because it requires them to try something else before they can get the drug that they want or was initially prescribed for them. And so I wanted to stop here and just, kind of hear your perspective on some of the conversations you've had around some of the pharmacy and then, well, actually, let's go to the next slide first. Got to remember, here's where we'll stop and talk. So when you think about utilization management, right, it really is, you kind of have to weigh what your overall philosophy is on utilization management and how important that member experience is against what can be some financial value of something like step therapy, or what clinical and safety goals are. And so I see a hand up. So definitely want to, let me see if I can see your name here. Yeah.
Representative Nose. Yeah.
Yes, Representative Nose. Yes.
So Siobhan sent me a text saying, like, is there a way we could join a consortium with another state or another entity to sort of get a better price? And I suspect that's something we could have our governor or maybe Ollie could explore. But I mean, we're going to continue to get the drug manufacturing ecosystem in this country to produce new therapies, new things. I mean, the question for me is, how much rationing of care are we willing to do? Are we willing to say to people, we can't afford the latest therapy? We have, like, I remember when the Hep C drugs first showed up back in 2014, like in my first term. And I mean, at least they were a cure, okay? Like, they're not a maintenance drug, that keeps you alive and keeps you going. They were at least a cure, but for a while, and the price has come down and their competition and, but like, I don't know, at some point, none of us want to say no, including this politician, but like at some point it's like, okay, like, look, we just can't afford to offer every innovative thing that comes along.
And that's the challenge. I mean, I think that's where I'm interested to hear the perspective of the PEBB board is, how much disruption in terms of something like utilization management are you comfortable with?
Yeah.
Is utilization management something that we want to focus on with the carriers, or do we want to look at other avenues to try to try to reduce costs and try to bend that cost curve.
And Ollie, I think it would be helpful if you could talk about opportunities with the RFP with this.
Yeah, I mean, thanks, Siobhan. We really haven't talked in great detail yet in this area for a proposal to bring to the board for an RFP. I mean, I think that would be part of the design and working with the board to develop. But I mean, there's a lot of opportunities, a consortium with other states. There's both purchasing initiatives, carving out pharmacy from medical. I mean, I will say, you know, we've done audits in the past on our current partners, and they are best in class. But I think it's an industry issue right now that everybody's grappling with. There's definitely within the OHA groups, Don can speak to this as well, looking at the GLP-1 drugs with the HERC, the Health Evidence Review Commission that PEBB and OEB are involved in. But I think it's kind of getting off the ground now. As more evidence rolls in, you know, I think that's the consideration of the board. Is it's always been an evidence-based board. Is you know, I think that we're starting to see that evidence roll in, so can back some of the next steps.
Thanks, Ollie. Kimberly, go ahead.
So I had a question about the step therapy. So do we have data that shows, does that work? I mean, like, you know, somebody, you know, I know that sometimes the newest, greatest drug, the doctor goes straight to that. And they know that they're gonna, maybe they don't know, but I believe they know that the pharmacy is gonna kick it back, and then we're gonna have to do prior authorization. And the prior authorization is gonna say, there's 3 other drugs ahead of this one. Do we know if person tries like first drug, the next drug in line, that they're happy and satisfied that they never ever go after the drug that the doctor initially prescribed? I mean, is there data about step therapy and how well that plays out and how people don't go after the final drug? If that's
I think
what it's
there
called.
is, I think there's some data out there, and I would definitely ask the carriers if they have information to share it. I will say some of the data I've seen is kind of mixed, and it depends on the therapeutic class. So I think in some therapeutic classes, step therapy absolutely makes sense. And I think the data is probably pretty solid. I think in some therapeutic classes, it might be a little, it might be more mixed data, if that makes sense.
Thank you.
Thanks. And I saw Don's hand too. Don, did you want to chime in?
Thanks. Although I have another observation, but I wanted to speak to that, Kimberly, that in order to move through the steps, the clinician has to make the case that the first ones didn't work. So they have to document in the medical record that steps 1 and 2 were ineffective and didn't meet or weren't able to be tolerated or whatever before they're allowed to request the next one that's part of that. So so if it isn't working, then we have a different issue. Because some people definitely should be falling off as those earlier steps have good evidence for being effective, subject to, as Sarah noted, the limitations of different meds in different classes. The questions that I have are a little bit upstream along the lines of the observations Ali was making. How much can contract negotiations with pharmacy benefit managers and between the carriers and the manufacturers impact costs? I know we have a special situation with this new class of medications that has known impact on diabetes control and known weight loss, but not nearly as much evidence about the long-term impacts, and particularly the long-term impacts that we hope we can see from weight loss for all of the heart disease and stroke and the other risks that come with obesity. Those data don't exist yet. So the array of questions we've been talking about here a lot of times, what role can be played upstream unless and until that evidence comes to exist?
Yeah, so I think let's hold that question for a second because we're going to talk a little bit more about vendor management. So I think you're talking about, how to push the vendors to, save money through contracting, which is kind of outside of the utilization management. But I agree, there can be some opportunity there, and we can talk about, if that's a place that PEB wants to focus through the RFP rather than on something like utilization management. I think that's part of what we want to get out of this meeting, is to better understand where PEB wants to prioritize in terms of looking at trying to level out some of this pharmacy spend.
And
I did want to
I guess
address-
the
Yeah,
the
go
one
ahead.
thing I want to chime in on this, we will have to meet the 3.4% every renewal cycle. And then the RFP is several years out. So we may have to employ multiple methods to get where we want to go. So I just want to name that too.
It might need to be an all of the above approach. I did want to acknowledge a couple comments that came in. Helen noted that prior auth is as disruptive as step therapy because most PA criteria also require use of other agents prior to approval. I'd say that's true in many cases. There's some prior auth criteria that really are only looking for diagnosis, not necessarily a step requirement. And then there was also a comment that step therapy has the ability to look back at claims data to see if the required step was trialed, so the claim can adjudicate. And that's true. In some cases, the step therapy can be automated. So the point of sale claim system can look back in time and see that the member has tried that step previously, and it can automatically approve the other treatment. So in those cases, step therapy really isn't very disruptive for the patient.
Thanks. And Representative Nose, did you want to chime in again?
I mean, that comment that she just responded to is exactly the whole tension around this, right? Which is our sort of check-in cost-saving mechanisms are another person's irritant denial of access to care, denial of treatment, right? And so I just think, I don't know if you want to just sort of shove that off onto the consultant and the plan administrator, and so that we all don't have to make that decision and say, okay, no, we're going to let the health plan that we sign up for sort of do that for us. But I think that's the tension you have to navigate. It's kind of like, okay, the dental benefit doesn't change very dramatically the way that the medical benefit changes. And so when a new dental therapy shows up, we have a little bit of time and the ability to sort of bring it into our system and plan for it and accommodate that change. And it doesn't cause all the premium conundrum that we experience with drugs.
Yeah. And Andy, did you want to weigh in too?
Well, I was just thinking, so I know that, with inconvenience to our members and things like that, but I think it would be also good to, be transparent with our members saying, well, do you want your premiums to go up? Do you want to pay more of a copay? I think that it's really, important that we say we're not doing this because we want to make your life miserable. This is a, cost savings because that cost is going to be transferred to you, or it could be. So I do think that, maybe, kind of getting that information out there would be as important as, so that they know why it's happening and how that affects them personally.
Thanks. Representative Nuss, were you going to say something again? You still have your hand up.
Yeah, and to that point, which is then the people that say, okay, so we're going to make you pay a little more for that thing. They're like, well, it's like you're punishing me for having a disease, right? That's the whole rub of this. But I think at some point, we have to figure out a way, how do we accommodate new therapies, new treatments, new drugs, bring them in that help prolong life and promote health. And also at some point figure out some things like I always want to talk about, how do we not throw so much care at people's end of life, which is not really our purview because we don't have a ton of retirees. Okay, I'm going to go back on mute now and just listen to the presentation.
I think you have some really good points, and you're right, that it really is the tension. And it's really something, we put these slides together knowing that it might be kind of provocative, but we really want, to explore some of that tension and think about, where do we want to prioritize? So let's go to the next slide. So we think about utilization management, and just here's some examples. So there's kind of a continuum. So this is an example for the GLP-1 drugs, which is everybody's favorite category right now. So like the least aggressive stance would be no prior authorization, no step therapy, and no quantity and duration limits. Member shows up at a pharmacy with a prescription for Ozempic and it's just paid for. That would be the least aggressive. It would mean the least member disruption. It would also mean the least cost savings, right? And then you can kind of move over to the right. So in the moderately aggressive realm would be something like a prior authorization required if there's no evidence of diabetes anywhere in the member's history. Maybe there's a step therapy that requires that the member uses metformin first. Metformin being like less than $10 a month tends to be first line for treatment of type 2 diabetes. And then it would be quantity limits based on what the FDA has approved for dose for something like Ozempic. So if someone wants to get twice the FDA approved dose, that prescription would be denied. So that'd be moderately aggressive. Then over on the right would be the most aggressive. So that would be like prior authorization would be required for every new prescription, even with evidence of diabetes. The provider would need to provide documentation of something like a hemoglobin A1C showing that the member's got type 2 diabetes that's not controlled with metformin. It would be a step therapy requirement for a 60 to 90-day trial of metformin, and then the member isn't able to control their diabetes with that drug. And then something like a quantity limit for each prescription plus a reauthorization required after 6 to 12 months to verify the benefit of therapy. I would say for this class of drugs, what I see is most employers are in that moderately aggressive realm, trending towards more aggressive, just given the rapid cost increase and utilization increase of these drugs. There are segments out there. I've got a couple of tech clients that are in that least aggressive space where they just are allowing open access because they want it to be an employee benefit and like a recruitment retention mechanism. So let's go to the next slide and we can see where PEBB is right now. And so we actually reached out to each of the carriers and asked what's going on currently for utilization management. So you can see some of the differences here across the carriers. So MODA, what they do is the pharmacist can enter a diagnosis of type 2 diabetes at the pharmacy. And then no prior authorization is required if the pharmacist enters that diagnosis. There's no step therapy requirement, so there's no requirement that the member uses something like metformin first. And they do have quantity limits in place based on the FDA approved dose. So this probably is in the moderately aggressive realm. Providence, what they do is they have a look back and look to see if the member has ever received a previous metformin prescription. And if they have, then the prescription is bypasses a prior authorization requirement. So prior auth is required if the member doesn't have a metformin history. They do have step therapy, which is prior use of either metformin or insulin, unless the patient has cardiovascular risk factors that would make them a candidate for the GLP-1, and then quantity limits apply. So that also falls into that moderately aggressive realm. Because again, it's not, the prior authorization isn't required for every prescription, only if there's an absence of metformin or a diagnosis. Kaiser, they require prior authorization always for every GLP-1 prescription. And they also require that the member takes the maximally tolerated metformin dose. Kaiser also has required steps through either SGLT2 drugs, sorry about that, or insulin, depending on the member's other medical conditions, and they have quantity limits. So Kaiser definitely is more on the right end of the continuum of more aggressive than what you're seeing in Moda and Providence. And I would say when we looked at the data, that kind of bears out. There's definitely less utilization of the GLP-1 drugs in the Kaiser population compared to what we see in Moda and Providence. And that's, to the question earlier, does step therapy work or does some of this utilization management work? It does seem to work in terms of limiting the utilization compared to something on the left end of the continuum. I think the open question is, what does that mean for member outcomes long term? And I think that the jury might still be out on that. So any questions on what you're seeing here? Is any of this surprising to you? All right, let's go to the next slide. Okay, so now we're moving away from drug management, that discussion about utilization management and formulary, what drugs are covered and for whom, and now talking about channel management. So this is how are the drugs being distributed to the members? And so there's different channels that prescription drugs can be purchased through, right? So there's a retail pharmacy, your Walgreens or your local independent on the corner. Typically that's a 30-day supply. We'll talk about mail order pharmacy or what we call retail 90. So that's an extended day supply, like a 3-month supply for a maintenance drug, something that a member is on long periods of time. That would be distributed either through mail order or through a dedicated network of pharmacies that dispense the 90-day supply. There's different options there. So you could have something like a voluntary, which I believe is what's in place now, where members can have the option to get mail order 90-day supply at a little lower copay. Some employers will do mandatory 90-day. So for maintenance drugs, after a certain number of fills at retail, the members are required to get 90-day prescriptions either through mail order or through a dedicated 90-day network. So that's an option that's out there. Specialty pharmacy, those are specialty drugs, complex chronic disease states, often injectables, sometimes oral drugs for things like cancer. Those are typically dispensed in a 30-day supply. Different options here are open specialty versus exclusive specialty. And we did ask each of the carriers where they were as far as specialty. So we'll hear their presentations there. And there can be different options as far as if it's always home delivery via mail for specialty, or there's carriers out there that offer where members can pick up their specialty prescriptions at a retail store. And then there's the medical benefit. So all of the data we've been showing so far is drugs dispensed through the pharmacy benefit. There's also this whole universe of drugs I think we might have talked about last year on that are dispensed through the medical benefit. And those are often infusions, injections that are given as part of a clinic or outpatient hospital visit. And so with those, there might be different options as far as how a member can get those medical benefit drugs. We go to the next slide. So here again, we kind of have a continuum from the least member disruption and the least cost savings over to the right? So least aggressive is kind of having a national network of pharmacies that includes all the major chains, national network of retail pharmacies, no mail order requirement, and then a member could use any specialty pharmacy. In the middle, which is kind of where PEBB is right now, where the generally, they have a national network of pharmacies. For maintenance drugs, there's an incentive for members to use mail order, but it's not required. And there might be a small list of network included specialty pharmacies. Over in the most aggressive would be a narrow network, so a limited number of pharmacies that members can use even for their one-time prescriptions. Maintenance requirement that after a certain number of fills, the member has to get mail order or has to go to a certain pharmacy outlet. And then specialty would be exclusive specialty pharmacy with no grace fills. So again, there's kind of that continuum of, on the left, there's the least member disruption, most open benefit to members, but also the least cost savings. And then over on the right, it's more disruption and more opportunity for potential cost savings. We go to the next slide. Let's actually go back before we talk about specialty drugs specifically. Sorry about that, Rose. So I just wanted to hear I wanted to stop here for a minute and just hear from the board what the thoughts are around network management and channel management for pharmacy. You know, how comfortable are you with something like mandatory mail or mandatory 90-day supply? Or is it most important to have that access for members at whatever their retail pharmacy is?
I mean, one of the things, I mean, right now I'm making the assumption that Kaiser is the most aggressive here in terms of the pharmacy management. And it would be helpful, you know, I know we're going to have all the carriers present and to know like what are the cost savings too related to pharmacy when it's more aggressive. And that's why I was mentioning earlier around, you know, like, are there ways for us to have a broader consortium? And I think this came up, maybe it was in the retreat, Ollie, or at some other point, but, you know, the state has a pharmacy benefit manager too. Like, what would that look like if PEBB were part of that? Like, what are the different ways that we would have the ability to control costs if we had more bargaining power to bring the costs down?
Yeah, PEB and OA both have arrangements with OPDP through MODA plans, and we stay in really close contact. They're actually part of OHA and part of our health policy and analytics division, and we definitely have like legal authority to look at multi-state purchasing initiatives, but I think it's I think it's something we just continue to talk with them about as they look for. They're really focused, you know, 100% of the time on enhancing that or getting more customers into that joint purchasing initiative, and that's something that we can look at taking advantage of even more than we already are.
Are there, yeah, Emily, go ahead.
Yeah, thank you for this presentation. It's really informative. And I'm just curious as to like, is there disproportionate impact in rural areas versus urban areas, coastal areas, Eastern Oregon? Like in terms of, you know, the network, mail, I just probably need more information about that aspect.
I think that's a great question and a great consideration. We've definitely asked the carriers, you know, what would be the potential savings for something like a mandatory 90-day. When we think about access in rural areas, I think sometimes the challenge can be those one-time urgent prescriptions, especially in areas that might be like considered pharmacy deserts, right? So I think we've heard a lot about independent pharmacies closing or the state of the pharmacy workforce. And that can be a challenge in rural areas or sometimes in inner city urban areas, depending on the area. Something like mail order, you know, there's pros and cons to mail order, right? You don't have that person, like that face-to-face interaction with the pharmacist, but US mail can go everywhere. And so that is something that's available for everybody, even if they do live in rural areas. But you're right, that's something to keep in mind is, you know, what does that rural pharmacy landscape look like? You know, and what is reasonable in terms of something like drive time for people that live in rural areas.
Thank you.
Ollie, were you planning to chime back in? I thought I saw you talking. I didn't know.
Oh, no.
Okay. Greg, go ahead.
Just from rural Oregon. You know, a lot of the individuals that I have talked to over the years, pharmacy really, I mean, just is not one of those things that comes up a lot, because I think the ability for pharmacy is so much greater than the ability for a knee specialist or a, you know, throat specialist. And so our pharmacy out here, we have everything from Rite Aid to Walmart to Safeway. And so, you know, I don't think we really lack a whole lot in pharmacy. Now I'm in, you know, I am in Umatilla. I'm not as bad as being down in, somewhere like, almost on the coast of California, or, California and Idaho. But then again, the mail order, as you were saying, mail order is, for the drugs you need every day, for that, I take cholesterol med, taking forever, that mail order, it comes when I need it if I want it. And I think we've been doing pretty good with that, just from my years of being out here.
That's good perspective. Thanks.
Go ahead, Ollie.
Oh, I appreciate Greg's perspective. I think, formularies is another area. I don't think we hear a lot of complaints from PEB members about their medications not being on the formulary. I think, when a drug is taken off the formulary, we actually get notice of how many members this will impact, and we have a whole process of how to communicate with them and a different intervention that might be available. And our plans do a good job of working with us to make sure members aren't impacted. But I just wanted to mention that what's on the formularies isn't something that we hear a ton of complaints from members about. Thank you.
Yeah, no, that's really helpful to know. Anyone else want to chime in on this? All right, thank you.
Okay, let's go to the next slide. We just wanted to talk a little bit about some of the challenges we're hearing from employers around specialty drugs. And, these are things like those molecular targeted therapies and those immunosuppressant drugs, right? So we're seeing that continued market growth, and we're expecting to see 50 to 55 new drugs every year in that specialty space approved by the FDA. Another thing to keep in mind too is the specialty drugs are kind of becoming a PBM profit center. So, data that we've seen, 2015, 17% of PBM gross profit was dispensing of specialty drugs. That's up to 33% of PBM profit. And that's a mix of factors there. In some ways, PBMs have been squeezed more on things like spread pricing, which isn't allowed in the PEBB contract. But that has reduced their revenue from other sources, and now they're making up more of it in the specialty space. And then there's the, typically you have exclusive specialty and you can get better pricing through exclusive specialty, but that also means that the same entity that is approving the prior authorizations is also dispensing the drug and benefiting from the dispensing of the drug. And so there can also be static pricing. So we hear a lot about specialty generic drugs where maybe they can be purchased through something like Mark Cuban, cost plus for a couple $100 a month. Through a PBM specialty pharmacy, sometimes they're more like $1,000 or $2,000 a month. And so it can take time for the pricing of specialty drugs to kind of catch up to the market because the PBM is dispensing in it. It does tend to be kind of a profit center. So we are hearing a lot of talk about how can we better manage specialty drugs. And so things we're hearing about are like a specialty drug carve out, where maybe it's a different vendor that's managing and dispensing the specialty drugs than the PBM overall. Some plans are looking at a specialty carve out, where there would be a different vendor that's doing the clinical reviews for the drug than the vendor that is dispensing the specialty drugs. So that's something that some of the clients are looking at. And then also kind of like a specialty channel carve out. And so we're talking with some employers now that are looking at a solution where maybe there's a specialty prescription, and usually a specialty prescription doesn't need to be dispensed same day. So maybe there's like a process where different specialty pharmacies could essentially bid on that prescription to provide the best price at the point of sale, and then that specialty pharmacy would be able to dispense. So it's really, I just wanted to put this up here because there's a lot of discussion around how do you decouple that specialty pharmacy benefit, or how can you make sure that you're getting the best price on some of these specialty drugs when it's one vendor that is kind of managing the whole process soup to nuts. So that's something to consider.
And one of the things that's just coming up for me too is like, how do we think strategically as well? Like, you know, we have legislative processes which we've used at times to bring down costs, like the 200% of Medicare, you know, hospital costs not exceeding that 200%. Are there ways that we could do something around where we buy our specialty drugs from? And if we're getting a better price, can there be a carve out for the 3.4% so that if there's something that's life-saving, maybe the legislature would approve that if we, you know, were smart about how we were figuring how to bring down the costs at the same time. Anyway, just like, I don't know, just wanted to be thinking out loud about like, you know, how can we tackle this problem? And we should also think about legislative ways we could tackle the problem too.
All right, let's go to the next slide. And so there was a series of questions that we posed to your vendors, and we're excited to hear from the carriers today. And where we really wanted to look at was, you know, around drug management, what are the options on formulary strategy? What is the formulary strategy that the carriers are using currently? We wanted to ask about what they're applying for utilization management for some of those fast growing categories that you saw earlier. We've asked the carriers about their specialty channel strategy. So are they requiring exclusive specialty or not? And then what is the strategy for non-specialty drugs? So do they have a maintenance drug program like mail order or retail 90? What are their offerings in that area? And then we also wanted to better understand what they're offering for member support and outcomes monitoring. So as we're seeing more members need drugs for these complex and chronic conditions like specialty drugs, what does the member journey look like for those members? How is something like care management integrated with the medical plan? How is information shared across? And then, you know, this is one I really wanted to hear more of. We're paying for a lot of these newer high cost drugs. What does the outcomes measurement look like over time? So 5 years from now, 10 years from now, will we have an answer to the question, you know, was the amount that was invested in some of these newer drugs, was it worth it? And how is that being monitored? And how can we calculate and assess long-term value for some of these drugs? And so that's kind of the highlights of the questions that we asked the vendors, and they all did provide detailed written responses as well as the presentations that you'll see today. I think we've got 7 minutes left before we turn it over. So if there's other pharmacy topics, you know, if there's other comments around really where the PEB board would like to focus when we think about pharmacy cost savings, I think we're definitely interested in hearing that.
Yes, I just want to invite board members to chime in, or Ali, any further thoughts on this before we start hearing from the carriers? Emily, did you want to share anything? Go ahead.
Yeah, I actually had a quick clarification question on the very second slide, the pie graph. The
Yeah.
3 categories making up over 58% of the PEB pharmacy spend. You've got like all other as 42% of that pie. I'm just curious if there's like, you know, a big, if you could break that down a little more.
Oh yeah, we could absolutely break down that 42%. We have all of that detail. We could take that as a follow-up and send you some more information. I think the thing to note is when you look at all other, that 42% of spend, that's trending at 3% a year.
So all of them
not
are
super exciting, right? So if you put everything else together, and there's some that are trending more and some less, but all of that is 3%. It's these other 3 categories that are really driving that 12% growth overall. So that's why we broke it up that way, but I'd be happy to provide you some more breakdowns too.
Okay, yeah, well, I appreciate the perspective on that.
Yeah, thanks.
All right, anyone else want to weigh in before we go to the carriers? Just really appreciate all this information. And yes, Dawn, please.
I have an observation. Some of those upstream some of those upstream, more creative, a little bit out of the box ideas about this, including the bidding. I haven't heard about that being applied to this, but it's being applied in some other ways across our economy, and it seems like it might be a really useful component of a cost-aware program. So I appreciate the sort of some of those out-of-the-box, less things that will impact the member experience less, and better yet, if it can impact the member and provider experience less, while maintaining a cost awareness and also holding the vendors sort of at every level accountable for participating in the cost controls and not supporting massive profits at any step along the way, which gets passed on eventually to members. And that would be from the manufacturers all the way down through the distribution to individuals. So thank you for that broader thinking. And I should specify, when I say providers there, I'm talking about prescribing clinicians. I'm not talking, there's another layer in there, which is health systems might be considered a provider, and a whole pharmacy chain might be considered a provider. When I'm thinking about who I'm particularly interested in protecting and streamlining for, its members themselves and their families and the clinicians and clinical teams who are taking care of them on the ground.
Thanks, Dawn. Okay, just giving folks another moment. So all of this really helpful. Thank you, Sarah. Thank you to the Mercer team. And I believe we have Providence is going to be presenting. We've got Helen and Gina with us to present today.
Good morning. Thank you, Board Chair Martin and Vice Chair Mautner. Very happy to be here today to talk to the full board and to the board staff regarding the PEBB pharmacy program at Providence Health Plan and the trends and future direction, with specific alignment in the questions that were asked by the Mercer consultants. So next slide, please. With me today is Gina Korab, who is our our director of our pharmacy consultation and client services area, and myself, Helen Noonan-Harnsberger. I'm VP of Pharmacy at Providence Health Plan. We're going to go through, just as was outlined by Sarah, drug management and our approaches in drug management, channel management, and our approaches with that, and in both areas covers some forward-thinking, futuristic kinds of concepts as well. And then we're also going to then take a few moments to talk about member support and outcomes monitoring, including the integration of our programs and services with providers and with our care management area. So with that, we'll get started. So I think forward 2 slides, please. So in the drug management area, as was outlined, the key things that we can work on are really utilization management and formulary management. And over the last 7 years, Providence Health Plan has made significant strides in making adjustments in our already evidence-based processes to really start to evaluate high impact drugs as defined by ICER. And as many of you know, ICER is the Institute for Clinical and Economic Review. It is an organization that is focused on fair pricing, fair access, and future innovation in pharmaceuticals. We have been also paying close attention to what the HERC is working on within Oregon and other specific utilization management tactics that are of interest in Oregon. But as we look at high impact drugs, those drugs that are increasing trends, those drugs that have the highest clinical value in disease states and serious prognosis, we have we have, as you've all seen too, seen the challenges of affordability and reimbursement. And so using the ICER predictive analytics approach and developing budget impact analyses has been an area that we've really become focused on as we look at pipeline coming forward and as we see new drugs come to the market and then get expanded indications, which is what we saw with the GLP agents, especially as we started to see the profound effect on weight loss in our diabetics. And so we've also focused on medical drug reimbursement, those infusions that were talked about briefly, although most of this presentation is focused on pharmacy benefit management side. But there is an equal and sometimes even more profound effect on costs in the medical drug and infusion space that's outside of the traditional outpatient pharmacy management. But what ICER's predictive analytics model allows us to do is a value assessment. Once we're able to do that with looking at these drugs and make decisions based on the clinical evidence, we can also then focus on specialty care coordination between providers, members, specialty pharmacies, and our PHP medical management and medical directors. All of that is really critically important as we set up things like tools like what are called real-time benefits, which are operating in our EMRs very profoundly, not just for primary care and not just for Providence physicians, but for physicians up and down the Willamette Valley and over on the east side of the mountains where, you know, as you know, virtually every physician office has an EMR in place. And the more that real-time benefits is used, the more we can drive a utilization to these lower cost options and to the alternatives that are on the formulary for PEBB. We're also exploring alternative reimbursement opportunities, value-based agreements, and specific single case agreements that are aligned really with outcomes from the pharmaceutical company side. These are newer contracts and it's emerging, especially for those $1 million gene therapies and cell therapies that are emerging. All of this work is really intended to drive affordability and access to care. And in doing so, add value to all of our communities here in Oregon through the use of quality medications that are closely aligned to health benefit price benchmarks. So next slide, please. Pharmacy cost and rebate management is really an important talking point to come up with. And it's in this area that we really start to see the impacts of channel management. As was outlined in the previous presentation, you know, part of channel management is assuring that we're achieving the lowest unit cost along with formulary placement based on the benefit design that the plan sponsor, which is all of you, offer for the member. Today, we have the generic brand and specialty categories of the PEBB benefit design. And we have a value list on the Providence formulary, which is a very small list of drugs that are placed at an ultra low cost share that's similar to a generic cost share for PEBB members. That's a list that is a list that we would recommend to the board to look at closely to see if there are additional high value products that you want to put on that list and to preferentially put them out there for your members in order to ensure that the member has some perspective on the low cost value drugs. Other alternatives include adding additional tiers. We frequently offer 5-tier and 6-tier formularies in our current marketplace with other employers and plan sponsors. On the pharmacy network side, we certainly have Retail 30 and Retail 90, as well as mail order and specialty. And we'll talk a little bit more specifically about specialty and how we operate our specialty program today. But specifically, we'll also talk about what % of the members have a 90-day supply in our Providence membership. The other area that I think is tantamount to cost management is rebate management. And of course, rebate management is partially or greatly influenced by utilization management as well. And so it is really this work to basically keep the lowest net cost product available to members that is critical. But one of the things, as you consider for the future, adding additional tiers, is that in doing so, you can have preferred brand and preferred and non-preferred brand tiers, which could be a tier 4 or 5, and frankly, there are rebates available for non-preferred drugs, and sometimes those are drugs you want to have available as a second line alternative for members, and it's good to be able to get rebates for those as well. But the primary approach that we use in managing that area is really working with our rebate aggregator, not just one time a year or once every 3 years, but consistently and routinely as we review formulary and pipeline to basically do contracting enhancements by drug, by therapeutic class, and by initiative that we administer. And you'll hear more about some of the initiatives we have in place today on the PEBB population. And then, as I mentioned briefly previously, the area of alternative reimbursement and value-based agreements on pharmaceuticals is growing, and something that we're talking actively with pharmaceutical companies about, as well as our rebate aggregator. And those can be opportunities that we can see not just in gene and cell therapies, but even in therapies such as weight loss management, which I know is something that is being considered strongly by the board. And all of this really requires that strong formulary assessment process that I talked about in slide 1 in order to really garner those maximal and optimal rebates that drive to your lowest net cost. And that's all. Well, that's what this work is all about, is bringing value to you as the plan sponsor. And, you know, we say it over and over again, but our philosophy is lowest net price for both caregivers and for lowest net price for members, lowest disruption for providers, direct care providers, and best value to the plan sponsor. I see I have a hand raised. I'm happy to take a question at this time.
Yeah, thanks.
Hi, Sarah.
Hey, I'm hoping you can talk a little bit more about lowest net cost for members. So sometimes what we hear is the carriers are managing to a lowest net cost, but sometimes that isn't visible to the members, especially if they have a higher deductible, because they're not getting the benefit of that, the rebate at the point of sale. Can you talk about how that works from the member perspective?
Yeah, I think, and it does depend on benefit design. And in the case of PEBB, which has a very robust benefit structure, which was specifically designed to keep costs low, we certainly don't see some of the problems that we see in other plan designs with high deductibles. But from our perspective, lowest net cost is achieved in, making sure that you purchase the drug at the lowest net cost and in the best channel you can get it in. You then apply rebates where applicable, and the lowest net cost in total for the member and for the plan sponsor. Now, how does that deliver itself in the marketplace? It delivers itself partially in the copays and in how the benefits are designed for the member, but also through programs like Copay Maximizer, which is a program we have in place for the PEB population, which delivers a zero cost share for the member while delivering a improved cost for the plan sponsor. And so while we're not directly providing rebates back to members, we have mechanisms to drive it to the lowest net cost. And the reality is that we are capable of doing rebates at point of sale if that's the plan design that the sponsor wants to have. And I think in the PEB benefit program, members have every opportunity for lowest net cost. And in the case of even generics, if they're less than the copay, they're paying less than the copay. So they're paying less than their brand copay most of the time, at least with the Providence plan. So those are the current drivers we have in place, but your point is taken that another lever that one could look at is what is the value of providing the rebates at point of sale. And those are things that we've actually looked at for other employers who have other benefit designs with a lot higher cost shares on them. Did that answer your question, Sarah?
Yeah, I did. Thank you very much. And yeah, you're right.
Okay.
PEB is unique because the benefit structure is pretty rich. So there's not a lot of big cost sharing. So you're able to make sure the members are getting the lowest net cost through the tiering and the copay structure rather than
Right.
sharing rebates point of sale. Thank you.
Right. And then always making sure that if a generic is ultra inexpensive and the copay is higher, that they get the lowest net cost. And believe me, I've compared my generic pricing to Mark Cuban's list and to GoodRx and to pretty much everybody, just to make sure that we are aligned on a unit cost basis and delivering high value for PEB in particular and for all of our plan sponsors and fully insured plans.
We are hearing from a lot. Yeah, we're hearing from a lot of the carriers that they're integrating discount card logic into the claims adjudication system, either GoodRx or some other discount card. Are you doing something similarly, or are you saying your pricing is such that you're competitive?
Yeah, right now it's that our pricing is competitive. We are on the verge of offering an actual comparator type of thing with either GoodRx or another vendor similar. But I think that, the key thing is that right now we're passing all of that value back to the plan and or to the members. Okay, I'll go to the next slide. Don't want to get behind on the schedule here. So with that, I'm going to turn the stage over to Dr. Korab, who's going to really talk to you about some specific utilization management strategies that were asked about in this questionnaire we received from Sarah and the Mercer team. So Gina?
Thank you, Helen. So I want to walk you through our Providence Health Plan strategy really on the targeted molecular therapies, as Helen mentioned and Sarah discussed earlier, specifically for rare diseases like cancer medications and multiple sclerosis. And really all of this starts with the focus on the PEB board and the members really in mind. So starting with the cancer products over on the left-hand portion of your screen, I want to point out a few important things. First, we follow the NCCN guidelines, which is the National Comprehensive Cancer Network, really to make our evidence-based recommendations and decisions. We closely monitor new research, as we know cancer is a really dynamic process. New recommendations change, and so we're really attuned and working with our consult specialists, like our Providence oncologists, really to ensure that we're meeting and following those guidelines. We also have an oncologist specifically that can help us with these complex cases when it comes to things like prior authorizations. So we have that direct consult availability, which is a really nice thing to have in considering that all the nuances of cancer therapies. We also know that cancer is turning into a chronic condition in a sense for certain cancers. And that just really depends. There are a lot of cancer therapies really that cannot have a cure at this point, but we know that a lot of these therapies do increase progression-free survival. So it's just really important that we're monitoring and we're really managing these options. So we do identify cases with our specialty team and move to oral agents and lower alternatives when available. Moving over to the multiple sclerosis category, we are focused really and recently reviewed our policy at the Pharmacy and Therapeutics Committee meeting and have really adopted a generic first strategy for all branded multiple sclerosis products. We know there are now several products available at the generic formulations. So really good news, I think, as a whole in this category. And that includes these medications for the more highly active form of multiple sclerosis. And so patients that are newly starting on branded multiple sclerosis drugs will require a step through to use these generic medications before branded coverage will be authorized. So on the next slide, I want to share with you some of the early results of this. If you want to move to the next slide. So we have seen this shift to generic and overall decrease in cost for these products as a whole. If you look at Q2, the total cost PMPM did increase just based on script count. But then if you look at Q2 and Q3, the script count has remained static, meaning that the script count has remained the same. And despite this, there's been a significant downward trend in the average cost per script. So just important to note that, you know, the ability to drive to generic utilization has significant impact. And so we will continue to focus on that kind of as our process moves forward, especially in the multiple sclerosis category. If you want to move to the next slide. I want to also highlight to you a design and really our strategy around Humira and the biosimilars that have entered the market. And again, the strategy around that lowest net cost approach. So the entrance of biosimilar competition really has significantly caused price erosion of the brand product Humira. And this is mostly based on manufacturer discounts. So if you look at that graphic on the right, you see Humira and a couple biosimilars are listed. Amgevity and Hadlima are the specific biosimilars, which are basically like a generic version of Humira. They're just large molecules, and so they're harder to make an actual generic of, but they have to be as safe and efficacious as the original product. So it's a really important move into this area. We targeted a first step strategy that really allowed access for adoption of the biosimilars, and that included preventing significant disruption to the members. And that was for a few reasons. First of all, if you see that slide again on the right, you can see with the rebates for Humira brand, as well as some of the other products, the net price is roughly the same. So we did consider financial implications, which is important because really good news that the branded Humira product and the cost has dropped significantly when rebates are factored in. But we also thought about the patient. And so we thought about how the quality of the administering device is utilized, really the volume of the dose, the different concentrations, and things of that nature to really increase member acceptance, and also to provide pathways for our providers or prescribers to transition. Currently, we do not have any members or very low utilization, but we consider that this will continue to move to biosimilars kind of in the future slowly, but again, with all of those things in mind to do it the most member-friendly way as possible. And if you want to move to the next slide, I do want to also discuss our GLP-1 management for diabetes specifically. So right now, the weight loss component is really not in this discussion. But we want to talk about how important this is to care for our members. So the American Diabetes Association guidelines do recommend GLP-1 therapy treatments early in therapy. And what that means is patients who have type 2 diabetes with also comorbidities such as heart disease, there is cardioprotection provided from these use of these therapies. So there are reasons to use GLP-1 medications for diabetes, and I think we are seeing more literature and guidelines, increasing the use of these. We expect more indications coming out so that and we are monitoring that to adopt our recommendations based on the new guidelines, the new indications, and really in the best interest of PEB and members. I do want to point out that there is only 228 members that we currently have out of 1,740 members that do not have a diagnosis on file. We believe that they would likely have diagnosis, or they may have some of these other pre-metabolic conditions that made their providers or prescribers choose these therapies. So it's a very low percent. It's actually about 15% is all out of the PEB membership that do not have the diagnosis currently on file. So we believe that most of these GLP-1s are being used for a diabetic therapy. If you want to go to the next slide. I also want to provide you with information really on our formulary initiatives and how our clinical pharmacists are working for PEB specifically, really to drive savings. And really, we are encouraged to cultivate creativity and come up with new programs, new initiatives, or anything that we can come up with, these new ideas to result or to provide savings for PEB. So for 2024, we have $17 million anticipated for projected savings, which is really, significant. And how we are doing this are many avenues. The first I want to highlight is the channel management program. So Helen is going to talk about this a little bit more in the future slide, but it's really ensuring cost-effective administration, really around these specialty medications, but really around all of our medications, especially infusible medications. So we'll talk about that. We also have formulary initiatives in place, therapeutic optimization, really driving to generic utilization, and especially for those generic specialty medications, as mentioned before, when there can be substantial, over 50% sometimes, discount from the branded products. And really what it is valuing those high, valued medications that are low cost options, really to support members with having that out-of-pocket low cost. And that includes optimizing biosimilars, kind of all of the things that we were talking about previously. We also have a copay maximizer program, ensuring maximum coupon dollars are saved for PEB, and really easing the way of the members. We also have our rebate strategy in place, as Helen has mentioned, but all of the work that we do around rebates is really then, and that is both in the medical as well as the pharmacy, drug management is passed back on through to PEB. So all of these initiatives are really designed around having the members receive care, aligning with our providers, prescribers, and really results in significant savings for PEB. Now I want to pass it back over to Helen. If you want to go on to the next slide, she's going to talk a little bit more about our channel management specifically.
Okay, thank you, Gina. So let's talk for a minute about specialty channel management. And our specific approach to specialty pharmacy is to assure that full value of purchasing discounts get passed through to you, and that you have a really what we're terming a PHP exclusive specialty network, which is built as a wrap network, with Credina Health being the primary specialty pharmacy, Credo, which is a national specialty pharmacy that can pick up some of the dispenses that cannot be done with through Credina because they can't get access to the drug, and then some additional few limited distribution pharmacies as needed. And our what we do is we contract with all of those pharmacies upfront and contract for every single drug and redo and review those contracts as time goes forward. So in other words, it's not static, the discount that you're getting for products, and it's constantly reviewed and compared to market rates. So the example I would leave or give you specifically is that we have an external consultant, national consultant that provides us database numbers from all of the other payers out there to look at what the market rate is for these products, all of them, from the ones that are only available from one pharmacy to the ones that are available at all pharmacies. And this exclusive specialty network gives us a lot of access. So what that results in is really the true and real commitment that you pay what we pay, and we are constantly working for you so that you're getting the lowest net cost. Um, and that's what my contracting team does, make sure that you are getting the lowest net cost. And then what that results in is it does allow the member to pay the lowest net price for the product, and when applied to their benefit, which is a very generous benefit at $100 copay for a specialty pharmacy, many of which are way over $5,000 to $6,000 and up to $50,000. That basically is really providing value to your program. Next slide, please. Some of the some things related to specialty spend and trend management and some best practices to optimize access, outcomes, and costs. We've talked a lot today about the importance of prior authorization based on safety, efficacy, and effectiveness, as well as following the guidelines and using entities like ICER to help us in making some of those assessments. And what we add on to that is that our specialty pharmacy program within the health plan includes a care coordination team with a pharmacy technician that is specifically working on member transitions, and then clinical pharmacists who are referring cases over to care management with each specialty case that has need for that. And that comes, and then our program comes with aggressive unit cost discounts on the broadest list of specialty products that you can find or use. We try to make sure that we have limited true exclusions. We do a closed formulary, as I believe I mentioned earlier, that does allow for clinical medical exception. We are evaluating more exclusionary types of formularies just to be cognizant of how they work. And those are things that could be brought forward to the PEBB board in the future if one wanted to go to more of an exclusionary list. But today, that's not something that's part of your plan. And I talked earlier about predictive analytics and contracting. And then, of course, with formulary, we're really focused on shift to generics or biosimilars when that's the right approach, and making sure that we've got good pipeline monitoring and various exclusions for non-covered treatments, such as weight loss. So those are the ways that we're managing specialty spend and trend, and these are the best practices that we utilize in our Providence formulary for PEBB. I see Sarah's got her hand up. Sarah.
Yeah, can you talk a little bit about what success are you having around some of the value-based agreements with pharmaceutical manufacturers? Have you been successful in negotiating true outcomes-based or value-based agreements for therapeutic categories that are significant in terms of overall plan spend?
I would say that we are currently most effective in those value-based contracts for various gene therapies for hemophilia A and beta thalassemia specifically. And we are evaluating how to do that in some of the other more commonly used categories. That's been very difficult. Some of the early contracts that have been proposed in that area really make no sense and don't really offer value to plan sponsors. So we've had to send other companies back to relook at what their goal is. And what we want to make sure of is that when we have those contracts with our plan sponsors, our self-funded plan sponsors, that it's transferable. So in other words, if PEB board decided to leave Providence Health Plan as one of your carriers, that those kinds of value-based contracts would follow PEB, right? So that, I mean, we have no interest in having any PEB money at any time, and we have no interest in losing PEB ever as a client, because it's really important to us that we're serving the state of Oregon public employees. But we are mindful of the fact that when you have therapies that are going to take 5 or more years to really demonstrate whether or not there's been a cure, or in some cases it could be longer, up to 10, we want to make sure that if you've invested $1 million, that you would get the value of that guarantee. So, there's just a lot of things to think of in that type of contracting, and we're trying to be thorough and make sure that there's good value for the money that the state of Oregon would spend for any of those therapies. So I guess that's a specific example. Did I answer your question, Sarah? Anything else?
You did. You did. Thank you.
Okay. All right. Thanks. Okay. Next slide, please. So this slide got labeled non-specialty pharmacy network, which is really your 30/60 retail network and mail order network. But this is really just a representation of where PEB is at today with this. And right now, over 36,000 network retail locations, all pharmacies in Oregon that are pharmacies today are part of our network. And then many pharmacies that are across the border in Northern California and Idaho and in Washington. But in addition, there are mail order pharmacies available specifically to you and your plan members. And within that retail 30/60 or 30/90, we have preferred and non-preferred pharmacies for medications. I like to use the word preferred or standard, right? So the preferred pharmacies are all the pharmacies that offer a 90-day supply, and that's most of the pharmacies. That's the most aggressive contract that we have. And the standard pharmacies are those that have chosen, maybe because of their size, maybe for other reasons, not to participate in the 90-day program. That is a little bit less of an aggressive contract. Within the PEB mail order program, there is a 2.5 retail copay. It's an incentive. That incentive probably could be a little bit more. We use that incentive based on your plan design for all 90-day supplies. And if you look at the graph on the far right, what you can see is that between the 90-day retail and our mail order pharmacies, we are driving 57% of the scripts for PEB through a 90-day supply, which is your most aggressive rate. I will acknowledge that 90-day retail is about it's about 5% better than retail 30. And compared to mail orders, another 4 to 5% better in unit cost. So there is a price incentive to go to mail order, and you'll see that the benchmark I use to compare PEB to is a plan sponsor that chose to do a mandatory mail order, and they have 29% of their dispensing through the mail order pharmacy. So that's just a little bit of a difference there. And then just looking at, kind of a case study of PEB members, maintenance medications at mail order are estimated to save about $1.20 PMPM. So there is still savings in mail order, but I know that's a hard decision to mandate mail order. It, from a member satisfaction standpoint, it's really frustrating. But what we found with the one client that we have that's very large also, once members moved there, they learned that they like mail orders. So part of it is getting members to try it. Transition, I think, is the hard part. So I think is Sarah, is that you that raised your hand
Yes.
again?
Sorry.
Yeah.
This is
Okay,
super
that's
helpful.
okay.
Yeah, this is the information we were hoping to get with some of the questions, so thank you. I just want to make sure that I understood correctly. So your 90-day retail, you said, it's a significant savings, maybe 5% better than the traditional like 30-day retail.
Yeah.
And currently there's 52% of members are using that. Is it a mandatory 90-day or is it
No,
an incentive?
No, it's the incentive. And one of the things is that the 2.5 times the copay applies at both 90-day retail, those 90-day preferred pharmacies, as well as 90-day mail order.
Thank you.
So
Yeah.
so the 2.5 times the copay is based on day supply. And the preferred pharmacies, in order to be part of the preferred network, they have to hit our contract. They have to decide to go that route, so to speak, in their contract and go for the more aggressive discount. So
Thank you. So and then that estimated savings of $1.20, that would be like a mandatory mail.
Yeah, exactly.
Okay. Thank you.
And it's probably important to call out in that middle bottom line is that the PEB contract today that's in place has no member pay the difference for generics, right? Which is a common way that historically plans have incented generic use. And there is a DAW1 logic that was put in place years ago, and Ollie and some of the board staff will remember the discussions that we had about that. But today, regardless of if the DAW1 logic is put in based on what was written on the prescription, then there's no member pay the difference. And that's an important part. You'd think, okay, well, how often can that happen? Well, it happens. And the last time I looked at the data, it was well over $2 million worth of cost. And so what that means is that, there are probably times that PEB members are getting brand when they ask for it from their doctor and the doctor wrote DAW. There are some rare exceptions where you really need DAW1 for a generic, but I think that that's something to look at from your benefits. That's like an easy way to save $2 million on your trend. So any of these ideas and things that we've mentioned, pro or con, that any of the board members or the Mercer staff want to talk to us about, we're happy to take offline and go deeper or ask or answer any questions today if you have them here today. Next slide, please. I think it's a transition to Gina. So Gina's going to go over really high level our member support and outcomes monitoring, and kind of give you kind of a walkthrough on that. And so Gina.
Yeah. So I want to walk you through really what it's like in that member journey, specifically in the from the standpoint of the complex drugs. So maybe a member who needs one of those molecular targeted therapies like cancer therapies, and really what's that, that from that lens and what that's like. So really going first, we have that member-provider relationship, deciding to pursue this type of therapy. Then the provider will send in that prior authorization. We do have a Pathfinder program really to ease the member's way on these complex cases, to really support them through this experience. We then have specialty clinical pharmacists reviewing those prior authorizations. Again, Helen mentioned all of these medications are going to require prior authorization to meet medical criteria. And then we also have that oncologist support that I had mentioned before, because there are unique situations where the guidelines may be less clear or silent on a certain, new subset of disease and things like that. So we have that support really to help us make those clinical decisions really about approval. We really want to make sure that these medications are safe and efficacious, and really, again, based on the clinical guidelines as well as practice guidelines. So then when a prior authorization is approved, the member will receive the letter stating that the treatment therapy is approved. We work then with the care team and care coordination to facilitate any details, and they might help with, for example, arranging transport, lab draws, appointments, all those other things that need to be in play in the mix with, we know, these disease states that are really complex. I also want to point out specifically that we also work closely with our Providence oncologist teams, so particularly in the Portland metro area, really to provide support and facilitate the process. We also have embedded clinical specialists as well as clinical specialist pharmacists really to help out and facilitate the process, whether that even be just getting that prescription in hand, as they are ready to leave the hospital. If you want to go to the next slide, I want to also talk about how important this is in terms of medical integration. So I know it was mentioned earlier about some carve in and carve out, but the medical integration and this piece is such a key to the whole entire process. So the member, it really supports the member's function in these high cost specialty drugs. And really, most of these medications, for example, in the cases of multiple sclerosis or cancer, the members might need infusion medications, or really medications that fall within the medical benefit, along with some of the oral medications that are really in the pharmacy benefit. So our clinical team really reviews these requests. Again, everything is based on prior authorizations, FDA labeling, NCCN guidelines. And we really want to support and ensure that the right therapy is selected, beneficial for the disease state, experts pulling in, working directly with our providers, our prescribers is really key to this whole process, collaborating with our care management team. That can be things like post-therapy, ensuring that there's no adverse events, any issues are addressed and remediated immediately, and really working on facilitating those facilities actually that have, the best rates and really are in line with the marketplace. So as you walk away from this presentation, I just really want to, hit home that we're really focused on the member experience, what it's like for the PEBB members. And really, we believe we are stewards, for them and having really successful care, especially in these important times of need. So thank you. And let me know if you have any questions. I don't know if there's anything else you wanted to add in, Helen?
No, I think we're good. We're open to questions and comments, pro and con. The only thing I might add is that, our focus on integration is not limited to the Portland service area. I think the example Gina used was in the Portland service area, but we certainly do the same types of care coordination, whether the member is in Eastern Oregon and is being transferred out of OHSU back to home, and making sure they have that support and that they know the medications are going to come, as well as into Southern Oregon and up and down the I-5 corridor. And we certainly maintain good working relationships with the specialists, although much more limited in number, right, in availability in the Willamette Valley and in Southern Oregon, and darn near hard to find except in Bend, right, Greg? So, you know, we know that that's a critical factor. And we know that when people are being transitioned then on medication, be it infusion therapy or be it an oral medication, there's a lot of early angst about those kinds of things because they've got a new condition and we got to make sure that we get the drugs to them. So I just want to add that because I know that we're a Portland, you know, centric organization. That's where our major treatment facilities are and our tertiary centers, including our cancer treatment center and our neurology treatment center and our institutes, clinical institutes, which are where we get most of the access to our specialists. But these are the specialists taking care of your members as well. The ones at Providence plus the ones at OHSU. And so we use the same techniques regardless of where the member ultimately resides.
So I do want to make sure we have a little bit of time for questions. We're a little bit over time here, but I want to hear from board members. Do folks have questions for Providence? I actually have a question around when you were talking about infusions for folks and integrating with a medical plan. A few years ago, we had conversations on the PEBB board around where folks were getting their pharmacy benefit and how that impacted price, whether they were able to get a home infusion or had to go to a medical facility. Can you just share a little bit about how that impacts price? And maybe, I mean, it may be that Ali is better positioned to respond on that. I'm not sure.
Yeah, I think I can respond. Certainly interested in Ali's perspective. We actually we use the same principles of lowest net cost and best therapy for the infusions as we do for the medical drugs. And one of the things we did about 5 years ago is put in place our version of a site of care program, which identified hospitals who were willing to contract for outpatient infusions at a market rate that was comparable to what we would see in a home infusion place. And, you know, that was kind of unheard of at the time, but it was a very successful program and is a very successful program across the hospitals in Oregon. And what that allowed us to do is to really manage those infusion costs at those outpatient infusion centers, which are really positioned with all the experts that they need for infusion right there on site, especially in those early stages of care. But simultaneously, the other piece that we did was really look at our home infusion provider network across the board and really approach contracting with those home infusion providers in a similar way. Because we also know that there comes a point where members don't want to choose to go into an outpatient hospital for those infusions, especially for the chronic therapies. And we had a number of cases of individuals who'd been on therapies for years, and they were so relieved that they could finally go home. They never knew that was an option. So home infusion is a really good option, but it's as important in that category of pharmacy type providers to which has nursing and all that, to make sure that not only are they quality providers, but that they have a lowest net cost that we're trying to achieve. So there is a market rate for everything. And if you focus on what is the market rate for a particular therapeutic, and you understand that, you know, everybody's purchasing from the same drugs, right? there is a way to manage this. It's still hard. The trends are still hot. You know, they're not perfect, but they could be also they could be also worse. So I think that's another area that we've really worked on behalf of PEB and many of our other clients.
Thanks, Helen. So any questions, any other questions from board members? All right, well, thank you both. And we're going to take a 10-minute break. So if folks can please come back at 11:40, I'll put it in the chat and I'll see you in 10 minutes. All right, it's 11:40. Welcome back, everyone. Do we have our presenter, Katie Sheeler, ready for us from MODA? Hello.
Hi,
All right,
how are you?
Good. So I am going to hand it over to you.
Okay, and I just want to make sure you can hear me okay.
Yes, I can hear you just fine.
Okay, well, thanks for having me. I'm very excited to be here. I am going to talk today about the MODA pharmacy program that we have in place for PEBB, and also want to make mention that on the call we have Carly Rodriguez, who's also a doctor of pharmacy. She's our vice president and chief pharmacy officer at MODA. Katie Schuler, is a clinical program manager and also a doctor of pharmacy. Next slide, Rose. We will start off by just describing our pharmacy program. It's really beyond a benefit. Our approach to administering the pharmacy benefits goes beyond just basic claims adjudication or ensuring that members just simply get their medications filled. We are not just a PBM. We stretch broader and we focus on the entire pharmacy services, as you'll see here, around the wheel or the multiple things that we touch as an administrator of the PEBB pharmacy benefit. And I'd say that we're not simply a vendor for PEBB, but we've been a long time committed partner. MODA, of course, is based here in Oregon, and most of our employees are here in Oregon as well. I grew up in Salem. I actually live here currently and know many public employees who get their benefits through PEBB. And so we really strive each day to ensure that the citizens of Oregon are supported and that we really provide the best care for our community. So our program ranges from ensuring that we have a well-designed pharmacy benefit with medications that are selected based on the science on whether or not they work, that they're safe, and overall cost to deliver these to our PEBB members and make sure that they have optimal care and support. And we're going to talk a lot about specialty pharmacy, as you've already heard earlier today, and that this has become more and more of our focus when we're talking about pharmacy spend and trend. Because medications are utilized both over the medical benefit and pharmacy benefit, it's important to know that we manage across both benefits, but for the purpose of this conversation and based on the questions posed to us by Mercer, we're going to focus more on those that are delivered under the pharmacy benefit, so self-administered medications. We've given a presentation in the past regarding our medical pharmacy initiatives, and happy to kind of delve into those at different times. But this presentation, we're going to focus on our cost containment levers to control costs, not simply shift them to members who actually need treatment, but really working behind the scenes to provide the best value. We're going to discuss the application of a uniform utilization management strategies across our benefits, and also securing rebates to achieve a lower net cost for a medication, given that safety and efficacy are the same. On the next slide, here are our program objectives, and we focus on 3 key areas to deliver value. So first and foremost, our priority with our program is to improve the health and lives of our members. We place specific focus on high touch and high cost conditions and medical pharmacy integration to improve the member outcomes. And this requires that we ensure medication use is optimized and clinically appropriate. Thanks, Sandy. Lastly, we want to streamline reimbursement. This is critical to the responsible management of overall drug spend, and it's accomplished through several different programs that we have in place, including site of care models for the medical pharmacy pieces, as well as preferred distribution channels, managing rebates, etc. And on the side of rebates, I wanted to just circle back to a previous comment that you made, Siobhan, and through you, Representative Nose, regarding partnership with consortium. So PEBB members and PEBB themselves are with MODA a part of a multi-state pharmacy consortium already, and that includes Oregon, Washington, Nevada, and Connecticut. It was called the Northwest Prescription Consortium, but we have expanded outside the Northwest and have rebranded under ArrayRx. And there are so many benefits that PEBB achieves through this consortium, including any rebates that are ascertained for PEBB members are 100% passed through to PEBB. And you'll hear me say this throughout the conversation today. That's a big deal. Rebates are not held, any portion of the rebates are not held for administrative purposes, for MOTA, for anyone. They're all given to PEBB. And though we've talked about this in the past, it might be worth having another conversation at a different time, or Siobhan, however, you know, if we want to provide you with written materials, but your idea was a good one, and I think it might be good to kind of revisit that value that we bring. So currently MOTA manages about 27,000 PEBB members, and the consortium continues to grow, and right now there's 800,000 managed members. And so when we're talking about pooling purchasing power, that really is, you know, a really great deal. And the focus of all partners really is on the same philosophy of high value medications that are rooted in evidence and have low value costs when they're equally safe and efficacious. But again, our focus today will be on the medication management of PEBB-specific pharmacy benefit and the self-administered portions. So we'll move to the next slide. And I have here listed, again, what you heard Providence talk through, as well as Mercer, in what they have guided us and what they asked us to speak to. I do want to note that it was asked that we provide in-depth narrative responses to the questions, and they're provided in an appendix. Mercer and the PEBB board has the full narrative response that MOTA has prepared that is not redacted. And so I do implore you, if you can, to read that narrative response, just because I think I read it to my 7-year-old daughter today and she loved it. So I think you might too. On the next slide, we'll get into the formulary management piece, which is really our bread and butter. So I've already mentioned that we are really rooted in evidence-based practices to create a high value, low net cost formulary. We have a high performance formulary that really is centered around generic and biosimilar utilization. Oh, thanks, Rose, for going there. So when we build a drug formulary, we have preferred consideration provided to those medications that provide a clear safety profile, clear safety advantages and improved effectiveness over other drugs in the category. Now, when we have a group of drugs and they all have similar safety and efficacy through clinical trials, we have a secondary consideration given to the individual products that present a low net cost benefit. So my training as a pharmacist was reviewing critical appraisal of literature. And that's what our team of pharmacists at MOTA do every day. And we really get into each drug, looking at the trials, how they were studied. And we consider all the published trials, current practice guidelines, the current place in therapy, documents from the FDA, including the medical reviews, the manufacturer dossier that has all the technical data. We consult with key opinion leaders, and we work in tandem with our Pharmacy and Therapeutics Committee to establish a benefit formulary that has preferred agents that provide the highest value formulary to our members. So we implemented a high performance formulary, as Mercer spoke to. It's an exclusionary formulary. And this was implemented for PEBB in 2018. And the focus was really to shift the cost curve. And I'm sure you recall, but we did have a great experience from implementing that benefit. There was a 4% per member per month cost avoidance when that benefit went into place, and that was a 1-year shift. However, we still glean benefit from that shift by continuing to bend the cost curve. So although that trend was seen in that 1 year over year performance, we're still realizing the benefits of this high performance formulary throughout. We also have in place a high cost generics program, a value tier, and a split fill program. These are programs we've talked about in the past. I'm happy to go into any. I just want to focus really quick on the split fill program. This program is applied to specific medications used for cancer treatment or management. We know a lot of chemotherapy agents have a high discontinuation rate because they are not as tolerable on our system as other medications. And in some studies, we see members in the studies having to stop the medication because they just cannot tolerate the drug. And so the split fill program manages the quantities where if a member qualifies for coverage of the medication, they meet the authorization criteria. They're only dispensed a 2-week supply of that medication for half the copayment. So we can really have a hands-on approach and ensure that they can tolerate the medication. This allows for more frequent touches with our specialty pharmacist team and really help manage the member on what to expect with side effects, management, etc. So if a member cannot tolerate the medication and they do have to stop use, instead of throwing away maybe 3 weeks of the medication, it only will be wasting a few days supply. So this really combats waste should a member not be able to tolerate the medication. And I want to talk a little bit more about our program to support members who are on cancer treatment in a little bit. On the next slide, I'm going to delve specifically into those 3 categories that Mercer identified as an overall trend increase. We'll start with the immunotherapies, and as you've already heard, that these are medications used to manage autoimmune conditions such as rheumatoid arthritis, psoriasis, inflammatory bowel disease, etc. The conditions are relatively common and they're becoming more and more common. The treatments are highly tolerated and members are pretty stable on the medications for many, many years. We have preferred agents in place, we always have. Rebates are collected in this space, and again, all rebates collected are passed through to PEBB 100%. We've seen biosimilars come to market in this space, most recently Humira, and this is really important because it creates competition to Humira, which has been the #1 drug across the world. And this really has provided us to get into long-term pricing strategies with the manufacturers of both the brand Humira product and the multiple biosimilar products. So our industry relations team has been engaged for many, many months, even before patent protection has been lost or before the biosimilars have come to market. And we've been evaluating the strategies to identify the lowest net cost product. So as you saw before, that might mean a product that has a low introductory price and or a product that has a high price and a rebate seen. So when we talk about lowest net cost, with members having the output the same with their out-of-pocket for specialty agents being held equal, the lowest net is really experienced by the plan, by what PEBB is paying. So we've had so much experience with biosimilars. There's been over 5 years of experience with these specialty medications, not specifically Humira, but other agents losing patent protection, and us having preferred products in the lower cost biosimilar space. So our provider community has gained familiarity with the biosimilars. It's so crucial though that the provider community accepts and prescribes these medications to help us really strengthen member confidence in these agents and achieve projected savings. So we work in collaboration with our preferred specialty pharmacy, Arden, to facilitate these product transitions and collaborate with the providers, provide member education so we can increase comfortability in switching to something that they have taken for many years and has worked, to an agent that is highly similar, but called something different. We've experienced this in the traditional drug space when Lipitor loses patent protection and we're now taking a generic medication. It might look different, but it's the same. I think our members are getting more and more comfortable with this idea being applied to specialty agents. Now, biosimilars, again, that do qualify for rebates, and rebates are achieved are 100% passed through. So biosimilars are just the same as other products. wanted to mention that we also have utilization management in place for immunotherapies. We have prior authorization, and so we have initiation of therapy that's evaluated before someone starts a medication, and we look at how the medication was studied, what is the FDA approved label, have they tried prior therapy, one, because it might be low cost, but more importantly, because those therapies are first line in treatments of these diseases. So generally when someone is diagnosed with rheumatoid arthritis, they don't just go right to Humira injection. They typically start with an oral agent. And so we want to make sure people are stepping up appropriately with their specialist providers. And then we also have continuation of therapy criteria. We want to make sure that the members are experiencing benefit from these specialty agents as expected before we say, okay, please continue this for a year. MODA is the one who makes those determinations based on the criteria that we've written. And we then pass it on to Arden as our specialty pharmacy to help support our member. So just wanted to make clear, it's not Arden who's making the decisions and dispensing the medications. MODA is the one who is supporting those decisions. And then lastly, I'll just mention really quickly the Access Guidance Program. It's been renamed from Copay Max Plus. You might remember those conversations in the past, but PEBB passed this, so effective January 1st, 2024. It's a copay accumulator program, and it maximizes the co-payments that are applied to more than 350 specialty drugs. So it protects against the high-cost therapies, similar to what Providence spoke to. It's through the claims adjudication process, and it adjusts the member cost sharing piece to increase the use of manufacturer copay assistance programs to generate savings to both the member and the plan. I'm not going to go too far into detail since we've discussed that, but I should have said in the beginning, I'd love for this to be a conversation. So if there's any questions, please feel free to jump in. On the next slide, we have molecular targeted therapies. So again, these are therapies that have been developed to find a specific gene mutation that causes a particular cell to grow into a cancer. So that targeted therapy affects only that abnormal cell versus chemotherapy that is non-selective and affects all cells. So these are highly specialized therapies. Our management is based upon evidence-based principles, again, running themes. We manage them consistent to all new market products, and they undergo comprehensive, rigorous evidence-based review process. This is super important in this category because a lot of these treatments are approved by the FDA through a fast track or breakthrough therapy accelerated approval pathway. And oftentimes that means they enter the market with minimal evidence for efficacy or safety. And we want to make sure that the medications actually have the results on the disease outcomes as expected. So a lot of times we'll see approval by the FDA saying studies still need to be done to ensure that this medication works as intended. So renewal criteria on these is very important. Our medications here, a few of them have had high discontinuation rates, so we do have them on a split fill program. And again, definitely the renewal criteria, we do look to make sure that the disease progression is to be where expected with the use of the medication. The next slide goes into diabetes management. So here, our formulary supports the American Diabetes Association guideline recommendations, which recognizes metformin as the first-line therapy for diabetes, but also then says second-line therapies really is up to the provider and member circumstances. So we heard about GLP-1s, SGLT2s, insulin, there's different categories, and depending on a member's specific management needs, if they have chronic kidney disease, cardiovascular disease, they can utilize one category versus another. We have preferred agents in these different subcategories, which rebates are collected, and pass through to PEBB. So our GLP-1 strategy has been hot topic conversation because of the off-label use for obesity. We have always had a utilization management strategy in place for these agents. When they first came out for diabetes, we had prior authorization on these medications to make sure they're being utilized correctly. So when we do a utilization management technique, we want to make sure that our edits aren't creating a burden to the system, a burden to providers, or a burden to members, that they're acting as they should be. So we often, every 6 months, measure what are our edits doing. And we found that we had a high approval rate of the GLP-1s, Ozempic, Trulicity, Victoza. People are utilizing them as they should. So instead of halting for a prior authorization, we moved to a step therapy that auto-approved these claims if they saw metformin claims history in the past. Then we were evaluating the step therapies, and we're seeing that a lot of them were coming to be reviewed because the metformin use was 2 years ago, 5 years ago, 1 year ago, and it wasn't being seen in the claims data. So though we were stopping it and reviewing it and charging PEBB for those reviews, and members were having to be turned away from the pharmacy, providers were having to send chart notes, we decided a more efficient strategy that would still confirm that the members using it for type 2 diabetes was a diagnosis edit at the point of service. So Mercer already talked about this earlier, but this is at the point of service. The pharmacy who's dispensing it enters in the diagnosis for which the medication is being utilized for. If it is for type 2 diabetes, the medication adjudicates. If it is not, or they don't have it written on the prescription, then it kicks out and we do a review of the medication. This ensures that it's not being utilized off-label for obesity, but it also provides efficiency because we saw people were utilizing metformin first. And so I just wanted to go back to what was being said earlier on how do we balance kind of the abrasion to members and providers, but also have utilization in place to make sure people are using the right med at the right time. And then the other comment I wanted to make here was the continuous glucose monitors. So you heard that this is really to lower the risk of glucose emergencies when people who are on insulin have really low blood sugars or really high. We decided, and it was effective for PEBB at the beginning of this year, that these devices, which previously were allowed to be dispensed as a durable medical equipment. So you would go to a store and get them as a DME supply and ask for reimbursement. We decided we would carve it out of DME and allow for the coverage under pharmacy exclusively. So members now can go to their retail location and get a CGM monitor. And we did this for several reasons. One, to improve access to members so they can get these more readily available than DME providers. And also because we have preferred CGMs. And when you ascertain these agents under a DME provider, we don't capture what's called the NDC, the code that you need to bill rebates. Under the pharmacy, we do. And so though people were utilizing our preferred agents, we weren't able to bill the rebates and collect that and pass to 100% to PEBB. We can do that now under pharmacy. So though we're seeing an increase of CGMs on the pharmacy benefit as shown earlier, this is intentional. And because of that, there's additional savings that are being passed through to PEBB. And my last note here is we know
I just want to,
yes.
can we pause for a moment? Sarah, go ahead and ask
Absolutely.
your question. Yeah.
Oh, yeah, thanks, Katie. I was just wondering, I thought I had seen something in email that there was a change happening at MODA with the GLP-1s for 2024, or maybe there was an audit or something that was going to happen because of like this, the pharmacist just entering it at the point of sale. Is there going to be some back end verification that the members do have diabetes? Okay.
Thank you. Yeah, so again, with any edit we have in place, we want to make sure it's working as intended. We never put it in place and say, call it a day. So one of the things with the RDX edit, required diagnosis of type 2 diabetes, we want to make sure that at the point of service, when type 2 diabetes is being entered, we want to validate that these patients really do have type 2 diabetes. And so yes, with our PBM, who is the back-end processor of claims, we are doing an audit of pharmacies to ensure that the members actually have type 2 diabetes. If they do not, then this would be fraud, waste, and abuse, and it would be dealt with through those channels. So thank you, Sarah. Closing the loop there is we are ensuring that pharmacies are acting in accordance with the law.
Will the results of that audit be shared with PEB?
Sure.
Thanks.
You're welcome. So my last note here is, you know, medications are great. I love them. I'm a pharmacist, but diabetes is more of a comprehensive management. And so just didn't want to glaze over the fact that we have other programs in place to really manage the member as a whole. Medications can't do it all. So those are listed here. So with my last few minutes, I wanted to go through the member support and outcomes monitoring. So next slide, Rose, and we'll just sit here for a moment. But before we, thank you. Before we launch into that, I did just want to tip my hat at channel management. So similarly, PED members do have access to 90-day at retail and mail order with the same benefit as 2.5 times a retail copayment. So there is an incentive, but not a requirement to fill 90 days at retail or mail order. The mail order in 90 days at retail, and those Choice 90 pharmacies are select pharmacies. It's not all of our retail pharmacies that offer it. Those reimbursements are pretty similar. One, you know, is a little bit better on generics, one's a little bit better on brand, but collectively, the mail order and the retail 90 are similar reimbursements. Okay, we're still going to sit here on this slide. I just want to comprehend or briefly go over that. Again, our goal is to enhance member care, and with specialty medications, we want to resolve the cost challenges through effective management of the products. So members aren't wanting really to take expensive medications, and we can manage all we want on the front end, but at the end of the day, members in a specific population have a particular need and they need medications. And those specialty medications are expensive, they work. And so we want to ensure that members are supported through every step of the way, and that if they are approved for a medication, or if they are needing this medication, that they take it correctly. And so it is critical that they have a partner in taking these medications, and that's why we've partnered with Arden Health for our specialty provider, or specialty pharmacy provider. We know that effective communication surrounding how to take these medications is paramount. Our goal is to keep the member out of the middle of the behind the scenes operational process involved when we review the prior authorizations all the way into getting them set up to have their fills sent to them for their specialty medications. We work directly with providers to ascertain all the information needed to evaluate whether they meet the criteria, medical necessity criteria for approval. We have an electronic prior authorization platform and workflow tool to have more efficient communication with providers to initiate, submit, and check the status of their coverage requests. And so I just want you to know, for every PA request, each pharmacist knows that there's a human at the end of that request. And we do all that we can to provide the correct care in a timely manner to ensure that our citizen is taken care of, that our public employee is being dealt with as we would want our father or brother or whomever. So on the next slide, I'll talk a little bit about once a prior authorization approved and we engage Arden Specialty Pharmacy, the members automatically enrolled into the high-touch interactive patient management program that Arden provides. Let's see, they really work to improve the adherence and treatment outcomes. They work to reduce gaps in care and inappropriate use, resulting in lower costs and better outcomes. Upon approval, okay, so Arden Specialty Pharmacy is alerted and they sign up into the high-touch interactive patient management program. The clinical guided approach really works to enhance member understanding of their disease state and prescribed therapy. So really taking time on the phone with the clinician to talk through what they know of their disease state, of their therapy, what is their expectation of side effects, how can they adhere to their medications, how can we improve the coordination with the patients and the caregivers and the healthcare providers to optimize their outcomes, how can we detect and prevent adverse events, assess and recommend appropriate preventative care, etc. So a lot of times when we get these diagnoses, it's a lot of information. You walk out of the provider's office, and in my experience with family members, you have a lot of questions. And so this is really a clinician within the care chain to pause and to provide that for our members. On the next slide, this really just demonstrates the complexity of the specialty pharmacy. All the steps here in the aqua box is what goes on behind the scenes while trying to streamline the process for the member, so they really see more of a simple 1, 2, 3 process. And on the last slide, this just really talks through what the patient management program does, utilizing the evidence-based clinical data to help remove obstacles to receive care and provide support to the members. It includes, Arden Specialty Pharmacy investigating their benefit coverage, managing through the prior authorization, re-enrollment or continuation of therapy, handle financial assistance. They make connections for support programs like advocacy groups or social determinants of health risk mitigation. They provide adherence management, side effect management, etc. I do want to just quickly mention that Arden also provides specific programs. They have an oncology clinical program. Arden is one of the limited group of specialty pharmacies who have achieved a distinction in oncology through the Accreditation Commission for Healthcare and through their multidisciplinary oncology professional advisory committee. They collaborate with outside organizations and individuals with expertise in the care and treatment of oncology patients, and that's a really big deal. I could go into their program, but for sake of time, I won't. This is one of my last slides. Each specialty prescription that the Arden clinical pharmacy team touches, they have an intervention every 4 prescriptions filled. And that could be, again, adherence, management of side effects, etc. So it's a lot of information. My point being is managing the formulary and using all the tools that we've talked about for decades is one thing, but it goes beyond those standard kind of tricks. We really want to ensure that we have bulk purchasing power so we can leverage our costs, which we do through the consortium. We really want to help members who need these medications utilize them properly and see the best outcomes. And I have so much more to say, but I want to leave time for questions and answers. I know we're 5 minutes behind and we have other business, so I'll stop and welcome any thoughts.
Thanks, Katie. Questions from board members? Rob, Representative Nose, go ahead, please.
All right, am I on mute? No. Just so that PEBB knows and so that the folks that have shared knows, we're going to have a discussion in the legislature about white bagging, which I'm sure is a thing that all of these specialty pharmacies and your PBMs have feelings about. I believe the bill is very narrowly tailored to oncology drugs, but I'll just sort of give you an alert to that whole discussion about how some oncologists have some concerns about how, again, a practice that's supposed to make things a little more efficient, more cost effective, also is potentially hurting their ability to practice.
And Representative, I just want to clarify, and that is for medications that are billed under the medical benefit because they are administered by a healthcare professional, where a specialty pharmacy will ascertain and ship the product to the provider office instead of the provider office
filling it
so
on
using
site.
their stock. So then it would
That's
be
right.
filled under
Yes.
pharmacy. Okay. Thank you.
Yeah, and it's less about their stock, and I think it's more about how they have to titrate the prescription the day of. So if just to get in, I won't get any more into the weeds, just want to give you a heads up, this is coming, and the bill is being modeled after what was done in Texas.
All right, thanks for the heads up on that.
Yep.
Other questions or comments? So I know that Ali has an update for us from the CIAO work group. If you can remind us what CIAO stands for too, and then share the update because they've been looking into the GLP-1 drugs.
Yeah, you bet, Siobhan. CIAO was the Strategies on Evidence and Outcomes work group that is a subgroup of the OEB board, and actually Greg and Andy from our PEBB board have been engaged with CIAO, looking at some data on coverage for GLP-1 drugs. I think what the plan is to bring their findings from the data to the PEBB board meeting next month in December. And it sounds like recommendations will be forthcoming at a later date, but this would be the first meeting we'll have an update on the GLP-1 work that CIAO's doing jointly with PEBB. And please add anything else, Sandy or Greg, if you'd like to.
All right, well, appreciate Andy and Greg, you paying attention to this and serving on that committee, and thanks for that update, Ali.
Yep.
And again, I'm gonna pause before we move to public comment to see if there's any other comments or questions board members have around this pharmacy discussion, which is a really big discussion. And so I'll draw attention to our first public comment. We just have one. And it is about GLP-1 drugs. So I don't know if you all saw it. We have 3 legislators weighing in, this was not Representative Nose. It was Lisa Reynolds, Hi Pham, Cyrus Javidi, weighing in to say it is
Javadi.
Javadi, thanks for that
Yep.
pronunciation fix. So essentially they're saying it's good that we're looking at the GLP-1 drugs. They support lifting the exclusion on them. So you all have this in your packet and can read it. Although I should call out, just in case any of them are here and want to speak to it. Do we have any of them who've joined the meeting today? Okay. Not hearing that any of them have joined. So just want to call your attention to that in the packet. So I actually think we're on track to end a little early today. So I know lots of folks are traveling this week, seeing friends and family. Have a safe holiday and enjoy your holiday. And really appreciate Mercer, you framing this discussion. Sarah, thanks for joining us. Thank you to our carrier presenters. It's definitely helpful for us to see that you provided all the information in your appendices that thoroughly answer the questions, and appreciate you joining us. And we will hear from Kaiser in December. This left us more time to have more robust discussion around pharmacy, and we will be taking it up again in another month. So thank you, everyone. And we are
Happy Thanksgiving.
Yes, happy Thanksgiving. And we are officially adjourning.
Bye. Be safe.
Thank you.